Good morning, everyone. Thank you so much for joining us. I'm Gail Nixick with ElderWorks Educational Services. We're very happy to sponsor this CE this morning, and I will be shortly introducing Margaret from CJE to give you a little bit of the introductions on our speakers this morning. But I just wanted to mention about the CE credit. This entire CE is being recorded. You will get an evaluation immediately after the completion of the webinar in your email, and please send that back to us and we will give you your certificate. Margaret will also tell you about the questions. If you can put those in the chat box, those will be asked to the presenters. We have a lot of great content this morning, and I want to be respectful of everybody's time. And so you can hear that information and ask the questions that you'd like. So I'm going to turn it over to Margaret, and thank you so much, everyone, and welcome again.
Good morning, everyone. My name is Margaret Danilovich. I'm the Senior Director of Research at CJE Senior Life. Thank you so much for being in attendance for this important topic. I'll be the moderator for today's session. So as you have questions while the presenters are speaking, please chat your questions in. We will use the format of each presenter introducing themselves, presenting their content, and then having time for Q&A at the end. So please chat your questions in, and we will answer as many questions as possible during our time for Q&A. So with that, I'm going to share our first presentation.
Do I start talking?
All right, I'm going to see if I can get this to work. I am Dr. Shana Margolis. I am an attending physician at the ShirleyRyan AbilityLab Pain Management Center. I'm also assistant professor of physical medicine and rehabilitation, and we're going to talk today about chronic pain. Today, our goals are to learn about risk factors for development of chronic pain, understand the pathophysiology of chronic pain, and identify medications used to treat chronic pain. You'll also understand interdisciplinary or multidisciplinary treatment of pain. So let's start with the pathophysiology of chronic pain. Pain is defined as physical suffering or distress as due to injury, illness, etc. You can think of it like a distressing sensation in a particular part of the body, for example, back pain. Or it can be something like mental or emotional suffering or torment, where you can say, like, I'm sorry, my news caused you so much pain. And then we can further break out pain into acute, chronic, and high impact chronic pain. And this is based on National Pain Society. So acute pain is an expected physiological experience to noxious stimuli that can become pathologic, is normally sudden in onset, time limited, and motivates behaviors to avoid actual or potential tissue injuries. Chronic pain is pain that occurs on at least half of the days for 6 months or more. High impact chronic pain is associated with substantial restriction of participation in work, social, and self-care activities for 6 months or more. The Institute of Medicine in 2011 had a briefing, and chronic pain is a huge problem. So chronic pain affects 116 million Americans at an annual cost of $635 billion per year. So this is a huge impact on our society. So the Institute of Medicine wanted to foster cultural transformation, work on individualizing care, and focus on self-management. They also wanted to incentivize that primary care and foster collaboration and let user research and educational focus. So if you think about pain, frequently people think about it using the biomedical model, whereas pain is a sensory event reflecting underlying disease or tissue damage. For example, you can have a muscle strain and that leads to back pain, for example. But really, if you're going to look at chronic pain is a disease of the person. So a traditional biomedical approach can't adequately address all of the pain-related problems of this patient population. So of all the approaches to the treatment of chronic pain, none has a stronger evidence basis than interdisciplinary care for efficacy, cost effectiveness, and lack of iatrogenic complications. When I think of chronic pain and how we do it where I work is using this biopsychosocial model. So you look at how is the impact on the physical structures affecting a patient psychologically, socially? Are they able to do the things they want to do? Go out with their friends and family? Is it making them feel more anxious, irritable, depressed? All of that can then fuel the pain and you can get stuck in these vicious cycles. So really the best way to treat chronic pain is using this biopsychosocial model. So risk factors for developing chronic pain. So chronic pain is pain continuing past the time of healing for that initial injury. So people can develop guarding of the injured area. They can have fear of movement and re-injury, regionalization or generalization of the pain. They can adopt a sick role, lose productivity and income. They can decrease in beneficial leisure activities, change in their family or community roles. And again, really, if you look at the biopsychosocial model, as they have pain, they might have increased pain catastrophizing, pain-related anxiety and fear. They might have helplessness, and then they, fear avoidance activities, things like that. And then they might have decreased ability to cope with the pain and not be ready to change or accept their pain. All of that together can lead to increased pain, psychological distress, as well as further physical disability. So yellow flags that a patient has chronic pain that's perhaps not being managed as best as possible is if the pain's not controlled or if it's localizing or expanding, it's growing. It started in their back, low back, then it's their mid back, then their upper back, it's growing. Their exams look different. Every time you see them, the exam is different. It doesn't quite make sense. They can have mood changes, be fearful of more pain or injury, lack of initiation of activities, fear avoidance behaviors, things like that, catastrophic thinking. They can have poor sleep because they're restless at night, and then if their body's not able to repair, restore, recover, it makes it harder to manage the pain the next day. Limited activity and function. They can't manage the flares. They're not interacting at work, in their community, with their family. So their world, I say, starts to shrink. It's like a circle shrinking down, and that they're doing less and less and less because of the pain. They might have had treatment failures where their medications aren't effective, or they had procedures that weren't helpful. They think of medication yellow flags. It could be that they're increasing dosages on the medications. We keep going up, 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 but they're not getting any better. So if you're just using more medicine without any benefit, more is just more. More isn't exactly helpful. They might start having long-acting opiates, and we're going to talk more about meds later, but they might start using long-acting opiates later, whereas that's really meant to be a later treatment, or earlier. That's meant to be a later treatment. So if they're using that early, that's kind of a yellow flag. If they're on multiple opiates, again, another yellow flag. Are they on a big opiate dose? Is their MME, which is morphine milliequivalents, greater than 50, 90, 200? How much opiates are they on? Are they continuing their meds despite side effects? It makes them feel nauseous, terrible, sleepy. They, go to the bathroom all the time, but they still want to take the medication. You'd think if the medication's having a lot of side effects, they would want to stop it. Are they using opioids with benzodiazepines? That puts them at high risk for respiratory depression and death. So that's not a good combination. And the goal of medications when we're talking about chronic pain is to improve people's functions. So if they're taking all this medicine and they're still not able to do PT or their activities, is their medicine really doing anything? If they're in bed all the time with meds and without meds, what are the medications really accomplishing? So let's go into medication a little more in detail. So a lot of different medication options we can consider in managing chronic pain. In 2016, the CDC guidelines came out where there was an updated 2014 systematic review where they really felt that non-opiate therapy is preferred for chronic pain. And opiates should only be used when risk-benefit favors pain and function. So it's not just managing pain, but also managing function. And the goal is to avoid concurrent benzodiazepines. So what kind of non-opiates can we look at? As well as opiates. But first, before you're picking any medicine, you really want to think about what is your treatment philosophy? Are you treating acute or chronic pain? What's the patient's diagnosis? Do they have nerve pain? Do they have muscular pain? Do they have bony pain? What kind of pain are we treating? And then you really want to treat pain and suffering. So are they having mood components because of their pain? Are they having trouble sleeping because of their pain? Are you comfortable prescribing opiates, not opiates? Are you going to do only opiates, opioids in conjunction with other adjunctive medications? Are you going to use medications with other interventions, therapies, injections, things like that? You really have to have a treatment philosophy of how you're going to best manage this patient. When it comes to the pharmacologics, again, there's a lot you want to think about before you start prescribing. Which medications have the most side effects? Is it going to affect their kidney, liver, heart, nervous system? What other meds are they on, and how is that going to interact? How compliant can they be with the medications, with the dosing timing intervals, with the medication itself? And the big thing is it going to help their function? You don't want to just be using meds to use meds, but the goal is really to improve their function and have safe meds that they're satisfied with. So I like this cartoon, and it says, well, dear, the doctor did say there could be side effects to those pills. So every pill, every medication has risks and benefits. You have to think about that when you're prescribing medications for chronic pain, whether they're non-opiate or opiate medications. You really want to think about your treatment philosophy again, and that's based on your training and comfort level, knowing all the options. Are you looking more active treatments, passive treatments, adjunctive treatments? What are your outcome measures? How are you measuring compliance? Really a lot to think about before starting to start patients on medications. So we'll go into medications in a bit more detail now. So lots of different kinds of medications you can use for chronic pain. There's topical treatments, things like lidocaine patch, lidocaine cream. Those are both prescription or over-the-counter. Frequently over-the-counter dosing is about 4%, prescription dosing about 5%, a little harder to get covered now that there are over-the-counter options. Flareup patch, which is a diclofenac patch, anti-inflammatory patch. Voltaren gel, which is diclofenac, another anti-inflammatory, now over-the-counter or prescription. Pennsaid is another diclofenac. It's drops that are topical. It comes in 1.5 or 2%. New capsaicin cream, which is over the counter. Capsaicin is the ingredient in hot peppers that helps provide a burning sensation, which floods the pain fibers, so your brain thinks about that sensation rather than the pain. Or there's compound creams that can be made that may have an anesthetic, neuropathic agent, anticonvulsant agent, muscle relaxer agent. You can have different compound creams that can be created for patients as well. Those do tend to have be expensive and can have some insurance limitations. So again, with each set of meds, we're going to look at the benefits and the risks. So benefits of topical treatments, they have good pain relief, they're not addictive, minimal systemic side effects, and many are over the counter. Risks, it can irritate the skin. Some people have issues with the adhesive or the creams themselves. They don't really penetrate real well to deeper structures. So things like low backs, it doesn't always work as well as things like wrists, knees, things like that. Frequently, they're not covered by insurance, although more recently there are more over-the-counter options that patients do have access to, and they can be expensive. Acetaminophen has been around for a long, long time. Benefits, it can help reduce pain, and it's not effective. Risks, it doesn't have much anti-inflammatory effect. It is more of an analgesic effect, and it can cause liver damage. Aspirin, benefits, it can reduce pain and inflammation, but risks, it can cause a lot of bleeding. It's not safe in children, and it can cause a lot of GI distress. Antidepressants we use a lot for chronic pain. I like this cartoon, how antidepressants should work. Side effects include weight loss, clear skin, a full head of hair, multiple job offers, abs of steel, love and companionship, sparkling personality. But we do use them a lot for chronic pain. Is what they found is not only do they treat mood, but many of these medications treat pain as well, and now are FDA approved for pain. So there's things like your SNRIs, which are your selective norepinephrine reuptake, selective serotonin and norepinephrine reuptake inhibitors. Things like Cymbalta, which the generic is duloxetine, Effexor or venlafaxine, Savella or Minicipran. So Cymbalta originally was FDA approved for depression, anxiety. Now it carries other FDA approvals for multiple pain diagnoses, things like chronic musculoskeletal pain, fibromyalgia, diabetic neuropathy. Effexor doesn't have as many FDA approved pain diagnoses because it was already generic. Savella is FDA approved for fibromyalgia. We also use some of the other antidepressants for pain and sleep, things like trazodone, amitriptyline or Elavil, nortriptyline or Pamelor, can help patients sleep and decrease their pain. Benefits, they can treat both muscular and neuropathic pain or nerve pain, and it can also treat mood. Risks or side effects, they can cause GI distress, weight gain. They can have some sexual side effects, can make patients drowsy. Sometimes some of the SNRIs will some people say they make them awake, some people say they make them drowsy, some people say it doesn't make them awake or drowsy, so it can affect people's sleep. And you have to titrate them slowly. You have to go up slowly and wean off slowly to minimize side effects. Little more detail on the trazodone, amitriptyline, nortriptyline. Those can also treat sleep, and they improve the REM sleep. Again, not addictive, but risk side effects. They can have cardiac arrhythmias or cause cardiac arrhythmias, so you want to be cautious in that. Frequently can cause weight gain, dry mouth, some morning sedation, and again, you have to go up slowly and wean off slowly. Anticonvulsants we use for neuropathic or nerve pain as well. Things like Neurontin or gabapentin, Lyric or pregabalin, Topamax, Release and Horizon or long-acting gabapentins. And again, gabapentin originally came out as an anti-seizure medicine or an anticonvulsant, but what they found was it was really good at controlling nerve pain. So now many of these medications carry neuropathic diagnoses for FDA approval. Lyric is also approved for fibromyalgia. Benefits of these, they can again treat both muscular and neuropathic pain. They're not addictive. Risks, side effects, they can cause sedation, weight gain, some cognitive impairment. And again, you have to go up slowly and down slowly, and they can cause mood changes. So you do want to keep an eye on that. Anti-inflammatories, again, you can get these over the counter or prescription strength. A lot of people will call them NSAIDs or non-steroidal anti-inflammatory drugs. They treat both inflammation and pain. Over-the-counter things are like ibuprofen or Advil, naproxen, or Aleve. Prescription ones, there is prescription strength ibuprofen, prescription strength naproxen, diclofenac, celecoxib, meloxicam, atodalec, indomethacin are just a few. There's others out there as well. And when you break up, you can think of your non-steroidal anti-inflammatories, and then also people will say COX-2s. So anti-inflammatories work by blocking COX-1 and or COX-2 from the arachidonic acid to when it forms thromboxane and prostaglandins. So the COX-2 inhibitors just block the COX-2 pathway, whereas the NSAIDs block both pathways. The reason that's important is COX-2 primarily mediates pain and fever and inflammation. So those are going to be more limited towards those things. If you have the COX-1 being affected, those support platelet function in the GI mucosa. So when you have a regular NSAID, that's why those come with more of a bleeding risk and more GI distress than if you're using a COX-2, since those are more protective for those areas. So benefits of NSAIDs, they can reduce pain, reduce inflammation. They're not addictive. I like this one, ibuprofen, your bestest friend in the entire world of Earth. Risks, so they do carry black box warning of GI disease, GI distress, heart disease, MI, bleeding, hypertension, stroke, renal dysfunction. Both the over-the-counter and the prescription dose anti-inflammatories carry these black box warnings. Antispasmodics are muscle relaxers. Things like Flexeril or cyclobenzaprine, methylcarbamol, scalaxin, robaxin, Amrex, baclofen, Sanaflex or tizanidine, Soma, Valium, Lapsid. Those are just a few. Big thing, they can cause sedation or make people feel kind of sedated or somnolent, as in this cartoon. Well, first, I think we'll cut back on those muscle relaxants. Risks and benefits. Benefits, they can relax the muscles and, it can cause sedation. So it's good if they have muscle tightness that's interfering with sleep. On the flip side, they can cause sedation. Bad if you're trying to take it during the day and it makes you tired and then you can't work, drive, do things like that. And they can also cause some cognitive impairment. So now we'll go into a little bit about opioid management. So first thing you have to think about when you're going to manage opiates, are you going to be a yes man? It's easy to say yes to opiates. It's much harder to say no to patients when they want opiates or they want more opiates. So what is your philosophy? Do you always say yes? Do you say no? Or are you somewhere in between? And there's different kinds of opiates. You can have short-acting opiates or long-acting opiates. Long-acting opiates are meant to get steady state in the system to kind of decrease baseline pain, where short-acting opiates are meant for earlier use, rescue medication to take as needed PRN. You would never want to put a patient on long-acting opiates if they're opioid naive. You want to have had them on short-acting opiates first. Lots of different kinds of short-acting opiates out there. There's tramadol or Ultram, Ultracet, which is tramadol with acetaminophen, Nucynta, which is tapentadol, Tylenol 3 and 4, which is acetaminophen with codeine. Hydrocodone acetaminophen, people will often refer to it as Norco, Vicodin, Lortab. Vicodin is a hydrocodone ibuprofen combination. Percocet is an oxycodone acetaminophen combination. So a lot of those short-acting opiates are mixed with either acetaminophen or some have ibuprofen in them, but more commonly acetaminophen works as a great adjunct to the opiate medications. There's short-acting oxycodone or oxycodone that does not have the acetaminophen component, short-acting morphine, Opana or oxymorphone, or Dilaudid or hydromorphone. Long-acting opiates, lots of different choices there. The Butrans patch is a buprenorphine patch. It's a once-a-week patch. Tramadol ER is a long-acting tramadol taken once per day. Oxycodone ER, OxyContin, or Xtampza are two of the brands that people have sometimes heard of. Those are generally dosed twice per day. Morphine, ER, there's different brands, Amescontin, Kadian, Avinza, Embeda. Those can be dosed once a day, twice a day, 3 times a day, depending on which product you're using. Nucynta ER is a long-acting Tapentadol twice a day generally. Exalgo is a long-acting hydromorphone dosed once a day. Opana ER, the brand name, is no longer on the market, but the generic, the long-acting oxymorphone, is still available. That's dosed twice a day. Zohydro or Hysingla ER are long-acting hydrocodone, methadone or fentanyl patch or Durgesic patch. The patches are generally changed every 2 to 3 days. Risks and benefits. Benefits, potent pain relief. They can decrease baseline pain. You can still, if you're have a patient on long-acting opiates, they can use short-acting opiates as needed for a more rescue or as needed basis. Risk side effects with opiates, things can be scary. They can get addicted. They can be dependent. Patients can go through withdrawal if they're stopped abruptly. They can get side effects like constipation, sedation, cognitive impairment, hyperhidrosis, which is excessive sweating, real scary respiratory depression or death even. So when you're thinking about opiates, you got to stop and also think about aberrant behaviors. And, can any of us predict aberrant behaviors? Well, there's things we can look at, of patients that may have had previous, opioid abuse or alcohol abuse or things like that. So trying to target who may not use their medications appropriately, because those patients are going to be at higher risk of complication. Think about who may not benefit from opiates. If we are going to use opiates, patients need to sign a patient agreement or an opioid contract that they're going to take their medications as prescribed, not get them from multiple providers. We do urine drug testing to make sure patients are taking what they're supposed to be taking, not mixing with any illicits. And again, we want to prevent diversion and abuse. I also, we check the Illinois prescription monitoring tool to make sure, again, that they're not getting opiates from multiple providers or concomitant benzodiazepines or things like that. What should we do when the pain gets worse? So do you just add more? Well, more can just be more. So you want to think about what other things can we look at besides medications? Do you mix up the medications? Do you do other adjunctive medications? You really want to look at things holistically. If you're using medications and you're using one thing and it's not getting better, or multiple medications, what else can we do to try to get patients feeling better? So again, I just wanted to touch briefly on interdisciplinary pain management. The World Health Organization pain rehab goals is for functional improvement, improvement in activities of daily living, relevant psychosocial improvement, rational pharmacologic management. So you want to look at not only analgesics, but also look at mood and sleep, and really getting patients back to leisure, sport, work, or other productive activity. So using interdisciplinary and multidisciplinary treatment is a great way to put the patient at the center of the team and give them as many tools in their toolbox to manage their pain. When I do interdisciplinary pain management, you've got a physician or someone like myself that's managing those medications, talking with the team. Do they need any procedures, any diagnostic workup? We have rehab nurses who talk about medications, they talk about nutrition. We have pain psychology, which is huge in that psychosocial model. Since when patients are in chronic pain, it can make them more anxious, irritable, depressed, which makes it harder to manage their pain. Physical therapy and occupational therapy. And a lot of people will say, well, I've had therapy before. Our focus is really on function. So not only do we look at strengthening range of motion, things like that, but we look at things like pacing, ergonomics, biomechanics. We really try to focus on function. We may do a cooking activity, pool-based or land-based therapy, Tai Chi, Qigong, Feldenkrais. There's many kinds of different movement-based therapies to add in more tools to the patient's toolbox to get them moving again. A lot of times when they don't move, they get more pain, and then they try to move, they get more pain, so they do less. They try to move, they get more pain, so they do less. They get stuck in a vicious cycle. So we want to break that cycle, but teach them how to pace. Biofeedback is a great adjunct in our program. Things like progressive muscle relaxation, deep breathing, imagery, great non-pharmacologic ways to decrease pain, decrease muscle tension, improve sleep. Vocational rehab, if they're not able to work, what can they do? I don't like to think about disability, but I think about ability. What can they do? Even if they can't do what they used to do, but what can they do now? Let's get patients moving back to work, back to school, back to their families and their lives. So again, the goal really is to decrease pain and improve function. So pacing, mindfulness, biofeedback, build their endurance, work on relaxation, posture, body mechanics, strengthening, range of motion. Everything we're doing is to decrease their pain, but also improve their function. And you really have to set the expectations. Sometimes the pain doesn't change. It depends on how long they've had it. But if they regain function and activity, that's still a win to me. Even if their pain is still a 6 out of 10, but now they're able to go to work, go to the store, be with their friends and family, go out to dinner again, they're managing their pain. That's still a win. We want to get them resuming movements and activities, look at posture, body mechanics, pacing, really teach them how to self-manage the pain, give them as many tools in their toolbox. A lot of it comes from our peers. How do you plan things out? How do you think about things? Really be able to manage their pain. And controlling the pain requires them to do a lot of work. It's this very active-based treatment. It's not passive, us doing good things to them, but them actively learning how to self-manage. You know, a lot of what we think about the medications are part of that program. Some patients don't want to be on medicine, but a lot of patients are. So again, we look at, is it helping their pain? Is it helping their mood, their sleep? Is it helping them function better, helping them cope with the pain, manage their flares? We really want to make sure that if we have a patient on medications, that it's really doing something. So again, interdisciplinary pain treatment, it's a team-based approach, active management of the pain to really work on reducing pain and improving function. Questions?
Thank you so much. We've got a few questions for you. So one question is, what sort of signs or symptoms or flags might social workers and care managers and others sort of look for if they're suspecting opioid abuse among their clients?
I think some of the things that you'd want to look for are, are the meds, are they asking for more? Are they wanting to go up on the dose? Does it seem like they seem confused or slurred? Do you smell other substances on them? Are their families noting that they're not able to do the things that they're supposed to do? Or, if they're working, are they not showing up on time? Are they not meeting their job requirements? Those can all be signs of abuse or misuse. You can ask, are they keeping their meds locked up? If they have any cognitive impairment, is anyone helping dispense the meds? Trying to look at things like that.
Great. Another question is there a way to test for the risk of addiction prior to prescribing opioids?
Yeah, so there's different risk management tools you can use. There's one called the ORT. There's different screening questionnaires, basically, that you can have patients fill out that have been validated to assess their risk for opioid abuse or misuse. And we do use some of those in the hospital. A lot of it is figuring out, do they have previous history of abuse, a previous history of misuse, alcohol, things like that. But there are some standardized tools that can be given to patients. We use a lot of different screening measures in our clinic, and you can use those tools as part of your screening measures before starting if you'd like.
Can you speak to the effectiveness of long-term opioids versus NSAIDs?
I mean, they're two totally different drug classes, and both can be effective in their own way, and both also have risks in their own regard. So risks with long-term NSAIDs, GI distress, bleeding, heart disease, stroke, risk with long-term opiates, addiction dependence, things like that. Both can be effective, and I do use both long-term in different patient populations, but you have to have a good discussion with patients prior to engaging in long-term treatment as to what are the risks and benefits, trying to determine what is the best treatment option for each patient subset.
So a question has come up about sort of getting patients to a pain physician. And so broadly, like, when should patients be referred to a chronic pain physician? Can they self-refer? How do people go ahead about sort of getting an evaluation more specifically at ShirleyRyan, but broadly, what are the sort of criteria for sending someone to a chronic pain physician?
So I think that you would want them to have chronic pain, so pain more than 3 to 6 months that's failed some initial treatment. At ShirleyRyan, people can self-refer or be referred by a physician. It would just be an insurance thing. If they're have an HMO, then certain insurances require a referral. But otherwise, patients are allowed to self-refer to us. You don't have to have a referral from a physician. When should you think about seeing a pain physician or refer is if what you're doing isn't working. I mean, if you go to some physical therapy, take a few medicines and you get better, then great. But if you're still having pain, if you're still having decreased function, if the meds aren't working the way you think they should be working, then that's when I would say see a pain physician. I will say with meds, a lot of times people think that they're supposed to make the pain go away. And I always counsel patients that in chronic pain, the goal of medications is not to make their pain go away, but I always say to take the edge off or bring it down about 3 points on the pain scale. So if they're expecting their 9 out of 10 pain to go to 0 out of 10 with a Norco, that's unrealistic. I always say I'd have to give you enough pain medicine that you wouldn't wake up in the morning. So we want to make sure we set that expectation that the pain meds are to decrease the pain, but it may not be to resolve the pain completely.
And how do you work with individuals who are stoic about taking medications until the pain gets to too high of a level and then they take too much to alleviate the pain? So suggestions for that.
So that's really where counseling and education can be helpful, is teaching patients how to pace, teaching patients how to stay ahead of the pain. If you wait till the pain is so high like that, it's harder for the meds to work, harder for the pain to come down, and then people are more at risk for overusing. So I think it's a lot of education up front of how to best manage their pain, how to pace, and how to really use their medications most appropriately to give them the most relief and take it in the safest way possible.
And so is the goal for people with chronic pain to be on some form of medication or to be completely medication free? What are your thoughts on that?
Depends on the patient. So we have some patients who we try to get off all medications based on what's going on with them or their preferences or how they're managing their meds. If we think there was abuse or misuse, we may try to get them off all opiates, but leave them on some other adjunctive meds. There's some patients that we need to put on meds because they're, we have to try to convince them that maybe, doing all these other things, they're not able to function. So it really is patient dependent. We've got patients on no meds, we've got patients on some meds, we've got patients on lots of meds. It really is what's the best plan for each individual patient.
And how does the presence of dementia or other memory loss complicate the use of opioids or other pain relieving medications?
That definitely plays a big factor because many pain medications can cause cognitive effects. So I think you have to really weigh that when you're managing patients with cognitive impairment or dementia. Trying to avoid those meds that cause cognitive effects where possible is good. Using as low of a dose as possible if you do have to use those medications, engaging their support system, whether it be significant others, other outside supports to help administer the medications or monitor them for side effects. Trying to use, if anything is sedating, you can try using it before bed, but if it's patients that wake up to go to the bathroom, that again is still an issue. So we really do have to take that into account in the elderly population and modify accordingly.
Are you ever using medical cannabis for patients?
So we do have patients that are on medical cannabis. Our clinic policy is that we don't write for the cards. And if patients are on medical cannabis, we don't also write for any opiates for them. They can be on other adjunctive meds, some of the anticonvulsants, antidepressants, anti-inflammatories, things like that. But I won't write for any opiates if they're also on medical cannabis. I think there's a good role for it. And a lot of patients will say they have results. I don't think there's enough data on it yet for me to feel comfortable writing for it.
And maybe our last question here is, we've made a lot of progress in treating so many conditions. Why is it so difficult to treat pain? Why do we have so few sort of real answers and treatments? And why does it appear to be kind of intractable in many cases for people?
I think chronic pain is really hard since it's so multifaceted. It's not just treating tissue damage or organ damage. When you look at the biopsychosocial model, there's so many factors that contribute to pain from a medical standpoint, but then a psychosocial standpoint as well, that it makes it very complicated to treat. And then there's no one size fits all. I think it's also a very subjective complaint, which makes it hard to treat as well. It's not like the bone is broken, now the bone is fixed. So it's very subjective, which makes it harder to treat as well, because every patient's, journey through pain is going to be different. So it makes it really hard to treat since it's so subjective and multifaceted.
Well, thank you very much, Dr. Margolis, for your time and your question and answer. This was wonderful. I'm going to turn it over to our next presenter.
Thanks for having me.
Hi, everyone. My name is Maya Yuen, and I'm a physical therapist and clinical manager for the Pain Management Center at ShirleyRyan AbilityLab. I actually work with Dr. Margolis. I've been in practice for 17 years, specializing in spine and other musculoskeletal conditions, including the treatment of chronic pain. My hope is that by the end of this presentation, you'll have a good understanding of the best treatments available for chronic pain management, that you'll have an understanding for other physical health conditions associated with chronic pain, how health behaviors can impact the management of chronic pain and why they're important, and finally, how to refer clients to various treatment options. So we'll first discuss non-pharmacological approaches. We're going to shift gears from Dr. Margolis' presentation and talk a little bit about non-pharmacological approaches. So as you can see, there are many interventions out there for the treatment of pain, and it can be super challenging for people to navigate which treatments are best for them and for their condition. I'll focus on some of these interventions, but really what I want you guys to get out of my portion of the lecture is kind of understanding a little bit more about different types of pain presentations and how that has an impact on what approach should be taken. And also I want you to have a good understanding for what are the, how do you identify the best kind of most ideal practices for this population. So, I think what's interesting, if you look at all of these recommendations, and I don't even have them all up there, if you start telling patients, if you start telling friends or family that you've got an ailment, it's amazing how many things come out of the woodworks about what you should try, magnets, or, certainly some are very valid, but, how do you know which ones are backed by the evidence? How do you know which ones are kind of more of a gimmick, kind of a fad type of treatment? So it is tough to navigate. So what is the best approach? There's unfortunately too many clinicians and patients alike that will focus on the severity of the pain, the location of the pain, and the belief system about the pain to guide their care. So, for example, a clinician may make the assumption that because a patient has high intensity of pain, that equals a severe injury. And so they might direct the patient to back off or avoid movement that hurts, when truly what we're understanding more now about persistent and chronic pain is that pain doesn't always necessarily equal harm. And we'll get into the details of that a little bit more. But in order to appropriately treat the pain, we must understand the primary mechanism. And Dr. Margolis, this is just reinforcing a little bit of what she was saying. So when it comes to understanding the appropriate treatment for pain, it's important to understand that timeline is really important. So tissue repairs pretty predictably. This graph kind of represents both pain associated with typical tissue injury as well as pain associated with persistent or chronic pain. We'll go into this a little bit more. So when you have pain that's more associated with the tissues, you're going to see, very predictable stuff. So of course, there's other factors that may affect recovery, such as overall health, like diabetes or smoking, which can delay healing. But in general, the process is pretty predictable and consistent. It can be broken down into 3 basic phases. The first phase is what we call the inflammatory phase. This phase lasts days. And the goal of this phase is to really, protect the tissue. And pain at this phase is an accurate signal of tissue damage. The second phase is what we consider to be the scarring phase. It's also known as the proliferative phase. This is the time when the body's laying down tissue. The goal of this phase is definitely to start moving tissue and kind of helping the new tissue that's being laid down to work properly. Pain is still a measure of injury, but it's less of an accurate measure of injury. So we have to look at multiple things. And then the last phase is going to be the remodeling phase. And that one is the phase that lasts what you can think of as months to a year. So pain is much less of an accurate signal of tissue injury at this point. And we do, as a goal for this, phase of care, we do want to stress and load the tissue, which, we may elicit a little bit of pain in the experience that patients have. So if a patient comes in with severe injury, but they've had pain for, over a year, we know that healing has primarily occurred, and we can actually push into this kind of uncomfortable zone and be safe. So I think a take-home message here is that the line here represents pain over time. So with normal kind of natural tissue healing, predictable tissue healing, or pain that's associated with a tissue injury, you'll see an elevation in pain initially that kind of plateaus, and then predictably over time, throughout the course of weeks and sometimes even months, you'll start to see that pain kind of settle back down. With persistent pain, or what we call pain that's a little less associated with the tissues, you'll see that this pain, even though time is passing and tissue's healing, the pain will continue to be elevated. So you'll have kind of dips and valleys, but in general, the pain is continuing to stay elevated longer than expected. So with these patients, you'll see that, again, pain is persisting, it's lasting longer than expected. They've tried many treatments with minimal to no relief. They may start to report spreading of symptoms to other areas, or just widespread generalized pain. And they may demonstrate limitations in functional, occupational, and leisure activities, or they'll just report that they're avoiding things altogether due to pain or even fear of pain. And then, as Dr. Margolis discussed, you'll start to see changes in mood and changes in sleep. So we know that once something serious has been ruled out, most things in the body are healed about as well as they can be healed by about 3 to 6 months, which is another reason why Dr. Margolis mentioned, how do you know when it's time to refer to, chronic pain? After it's been 3 to 6 months, we know tissue healing has occurred for the most part. So now the pain is likely less about tissue and more about sensitivity of the nervous system. So this illustration, I like it because this little guy right here is a little brain. It's actually a brain man. I put a reference to a 5-minute video that's really great. And this illustrates how, the brain and the nervous system is the primary issue, and you still have the potential for tissue kind of contribution, but it's certainly more of a supplemental piece of it. So back to the original question, what is the best approach? So because persistent pain is more centrally or nervous system mediated, the approach needs to target the central nervous system versus targeting specific tissue only. So, Dr. Margolis talked about the biopsychosocial approach, but it is a really necessary treatment for chronic pain. And part of that would be an interdisciplinary approach. I'm going to talk about the importance of pain science education as an essential part of treatment, active treatment versus utilizing passive therapies, and then encouragement of this self-reliance, self-efficacy. This is going to be really important in creating long-term management for the patient. So in speaking to the biopsychosocial model, we know that this is truly the best approach. I think when seeking care for any complex illness, but especially for the treatment of complex pain, it's important that the provider acknowledge and address the dynamic interactions between biological, psychological, and social components, whether it's part of an interdisciplinary model or it's just a sole individual provider. As part of, a good interdisciplinary approach, there's a lot of evidence to suggest that this is truly, the gold standard. I will be focusing a little bit more on providing information for the best care in the context of physical therapy that might be relevant for patients who don't have access to an interdisciplinary model. This model isn't unfortunately always readily available to patients. Things like location or insurance coverage, time commitment, et cetera, can create a barrier. So in the absence of an interdisciplinary team, clinicians such as a physical therapist will need to apply these biopsychosocial approaches that look at the whole person and the whole situation. And part of doing that, and certainly for any professional, is to make sure that you are instituting a very thorough assessment. So, you know, it should look at multiple systems, consider social and psychological aspects. I know I'm preaching to the choir with that one. I know that that's something that's already valued here, but definitely not just looking at things from that biomedical model, which, as Dr. Margolis discussed, is not going to be the best way to explain the types of symptoms that these patients are having. So with a thorough assessment, you want to ask about prior treatment. What does the patient want to get out of their therapy? What are their goals? Get them involved in goal planning, thoughts and beliefs about pain. I think this one has really made a difference for me as a clinician, really getting the patient's take on what's going on. And then I also think that outcome measures can be pretty beneficial. You know, outcome measures, they're an important tool in, you know, both informing your care, figuring out what are the areas that I need to treat, but also it's a really great screening tool to understand when people need to be referred out to a specialist or even to that interdisciplinary approach that is going to require a little bit more of a higher level of, you know, multiple providers. I think the big thing about the assessment is it's such an important part for the patient. It's really the place where patients can feel validated and safe and listened to, or it's the time when they can come away from it feeling once again dismissed. These patients have likely been seen by many, many people with failed attempts or, you know, failed attempts at definitely abolishing their pain or even reducing their pain. So I think building the rapport is really important. I think part of that rapport building is really validating and letting the patient know that that you believe them, that their pain is real. So that's important for a thorough assessment. As mentioned, another key approach in the treatment of chronic pain is pain science education. There's strong evidence in the research to suggest that pain science can have an important impact on the recovery of patients' persistent or complex pain. And some of the research shows that education alone can have a positive effect on pain rating, disability, movement, catastrophic thinking, pain anxiety, coping, fear avoidance or fear of movement, and healthcare utilization. I think this is, you know, I want to take a moment to pause and think about this. Pain science education alone can have an impact on those outcomes. I think that's pretty powerful. And I think that's a reason why that has to be a component of the treatment of chronic pain. When providing education to patients about their pain, it's important to make sure you validate them, their pain is real. Explain that there are known physiological changes that occur in the central and peripheral nervous system that account for their symptoms. The nervous system can learn pain. So the more you're in pain, the better your body, your nervous system becomes at creating a pain or a danger response. And then lastly, it's also important for patients to know that pain is not always an accurate measure of tissue health. I want to share with you a kind of metaphor or kind of education tool that I use with patients very often. It's really important to use metaphors and analogies when trying to help patients understand pain and pain science. The goal is to really give them a more accurate picture of what's happening with their persistent pain. So in this example, we're comparing pain and the nervous system to an alarm system. So we explain that when something harmful occurs, such as stepping on a nail or putting your hand on a hot, pan, your alarm goes off, altering your spinal cord and brain, or alerting your spinal cord and brain, letting them know that something dangerous or harmful is occurring. So in this case, these are very appropriate signals, right? This allows your body to really react in a way that protects you. You might remove your hand from the pain, or you might lift your foot up away from a nail on the floor. And then once the stimulus is removed, gradually your alarm system should be calming back down. In the presence of injury, it's normal for this to take a day or two, so your body might still continue to have increased sensitivity to stimuli, but that's kind of a normal response to work to protect the area. So on this left-hand side, this is kind of where we are normally kind of our baseline, normal excited level. There's a lot of stimulus that has to occur in order to, this firing level is where the alarm system will start to go off. So when patients start to have persistent or chronic pain, your kind of normal excited level isn't low down here anymore. The threshold's a bit higher. So there's a lot less room for activities to fire off the alarm system. So it's important for them to know that sometimes, we're not 100% sure why that is, the alarm system won't reset back to normal within the expected time frame. The alarm system becomes overly sensitive, and it doesn't take a lot of movement or stimulus to activate that system. And an important part, I think, of the examination when I see patients in physical therapy is to really provide them with a physical therapy diagnosis or an explanation for why they continue to have this pain. I'll say things such as, in my opinion, part of the reason why you continue to have this persistent pain is that you have an extra sensitive nervous system, which can happen when people have had persistent pain. And instead of addressing like specific tissues, which is likely what patients have done in the past, we will be focusing on interventions aimed at calming down your alarm system. And this will gradually help you to move more and eventually experience less pain. So part of the treatment for desensitizing that highly excitable nervous system is involving, active care. So there's good research and there's a consensus that active therapy results in positive outcomes for patients. So there's not a lot of consensus to specifically the activity. So core strengthening, stretching, walking, cardiovascular exercises like McKenzie exercises. And there's no consensus as to the frequency or the duration, but there is a really strong agreement that some form of active movement is beneficial. There is also growing concern in the literature that passive care, such as like massage and ultrasound, stretching, things that are done to the patient, can actually have a negative impact by increasing fear of increased injury with physical activity. Patients might lean towards dependency towards their medical providers and decrease their confidence in their own ability to care for themselves. So examples of active care, strengthening and mobility, cardiovascular conditioning, ergonomics, body mechanics, pacing strategies, which includes graded exposure, sensory retraining, and motor retraining. So there's graded motor imagery that will do desensitization and localization that is specifically targeting some of these changes in the nervous system. And I thought it would be helpful to give examples of what passive treatment looks like. So massage therapy, manual therapy, ultrasound, electrical stimulation like TENS units, chiropractic care can sometimes be passive. But what's important is to note that I'm not by any means saying that these interventions are not good or that they're evil or that they're wrong, but there is a time and a place for them. So it really is all about the timing. So if you think back to the early slide that I showed when we have that normal kind of tissue-based pain, that's when these modalities are likely to be more effective. That's when really, we should be using them. But once we identify that patients are, their pain level is persisting beyond normal tissue healing, we really need to start looking at more effective methods. And there's growing evidence that these passive interventions are not so effective for pain that's not associated with tissues. Self-efficacy is the last component in what I believe to be an important part of treatment of chronic pain. So one thing that really, I think, highlights self-efficacy that I actually quote to my patients all the time is taken from this Chinese proverb: give a person a fish and you feed them for a day, teach a person to fish and you feed them for a lifetime. So, really teaching self-efficacy is going to be very important. What that means is, applying principles. Initially, we provide education, direction, rationale to patients, but we put the responsibility back onto the patient to apply the principles we've been working on, not just verbalizing understanding or, reciting back what we've said, but actually putting them into daily use. And I would say, a good clinician, a good physical therapist is doing that from day one. Encouraging independent problem solving. So again, initially giving them kind of direction, but quickly holding the patient accountable. So saying, well, what do you think would be a good strategy if you start to have pain during your camping trip? And they hate this at first. At first, it's so frustrating. But eventually it results in really a great sense of pride for the patient, self-control. And, when I'm discharging patients and I'm asking them, like, what do you feel like was the most effective thing that we did together? By and large, they say, you giving me the tools to know what to do. And it's almost like I'm spoon feeding them the answer that I want to hear, but that's when I know I've done my job. Another really important piece of this that I think is sometimes missed by clinicians is providing a good flare-up plan early on, letting the patient know, flare-ups are really normal. You're bound to get a flare-up. Sometimes you'll get a flare-up while you're in my care. Sometimes it'll happen once I've discharged you, but I want the patient to be armed with a really good plan for what to do in case of a flare-up. However, I think part of a flare-up plan is reminding them that there's no need to panic. This is normal, that they can get through it, kind of giving themselves positive self-talk, which we'll get into a little bit more, but really leaning on the things that have worked for them, trusting themselves, trusting the work that they've done. And lastly, an important part of self-efficacy is just really encouraging consolidation of medical providers. Earlier on, when I talked about assessment, I think during the assessment piece, it's really important to ensure that we're rebuilding the trust in the medical profession for some of these patients that really feel like they've been dismissed and sidelined and not really understood. So, during the assessment, I'll take it as an opportunity to say, it sounds like you and your last physical therapist really worked hard at trying different things. And although, it sounds like you didn't get as much of a relief as you would have liked, now we have a better understanding for what works for you and what doesn't work for you. I think the worst thing we can do for patients is throw other providers under the bus and tell them, well, that's not how you treat chronic pain, or they didn't do, pain science education. I can't believe that. It's just really harmful to the patient to take away trust for that healthcare provider, but also the healthcare system in general. And I just think encouraging them to consolidate medical providers, encouraging them to trust their medical providers. I think this is so key, not only in decreasing utilization of services, but also the more people that they see, the more diagnoses they're going to get and the more treatment recommendations they're going to get. And that's going to take them down a path of, really unhelpful thoughts and catastrophic thinking. And, well, have I been treated incorrectly this whole time because no one told me I had an SI joint problem? So really, and I'm very transparent with them about this is what happens sometimes when you see so many providers. They give you different diagnoses when in fact, this kind of nervous system, upregulation and kind of what we call central sensitization is a really great model that helps explain your spreading symptoms and your persistent symptoms. So getting them on board and buying into that pain science education again is really important in helping to consolidate medical providers. Patients that are successful in their chronic pain management journey will demonstrate really good positive health behaviors, and that includes adopting helpful attitudes and behaviors. They will address their psychological health, and they will address their physical health very effectively. Adopting helpful attitudes and behaviors. This one is really important in when we think about a psychologically informed approach that can be more effective than PT. So, when a patient's having, unhelpful thoughts, as a physical therapist, it's really important for me to kind of stop what we're doing, identify that thought, and, pause and say, okay, so what I just heard you say is that you feel like your knee, there's tearing of your knee. You feel like your knee is falling apart. Let's talk about that statement. How do you feel about that statement? How does that statement make you feel? And just really kind of reframing and giving the patient the opportunity to understand how their pain can affect, their thoughts can affect their pain. So I explain to patients that thoughts and beliefs are nerve impulses. They can really amp up the alarm system and reinforce learned behavior. And learned pain. And when people give into the negative thoughts and catastrophic thinking, it can have a direct impact on their pain. So identifying thought distortions and catastrophic thinking is important, identifying fear avoidant behavior and calling it out and pointing it out, and really starting to implement helpful coping strategies. So in physical therapy, we'll initiate that process, but again, we talked earlier about use of outcome measures. At some point, it's really important to be able to identify patients that clearly need to see a counselor, need to see, mental health specialists in order to give good tools for coping strategies. What the good news is they can also downregulate their alarm system and unlearn their pain when they use helpful thoughts and attitudes. And then again, maintaining a self-reliant approach is another way of enforcing helpful attitudes and beliefs. So when patients give into the negative thoughts and catastrophic thinking, it can have a direct impact on their pain because, again, thoughts and beliefs are nerve impulses that go to the brain, that go to the spinal cord. So if a patient's thinking, gosh, severe pain means that there's severe injury. If I hurt, I must be causing harm. Moving hurts, so I need to stop moving to avoid injury. Something must be really wrong with me if I'm not getting better. And I just need to have someone massage the pain out of my IT band. And if they do not know what is wrong with me, it must be really serious. So that goes again with, let's try to find a clinician that can explain to the patient, we know what happens physiologically with persistent pain. We know why your pain is spreading. We know why your pain is persistent. It's not a mystery. I think that's really helpful for patients. So all of these thoughts can really contribute to pain, and more pain. But it can also work in the opposite direction. When patients reframe thought distortions, they begin to adopt positive or helpful thoughts, then they can unlearn some of the learned pain and downregulate their alarm system. So I know what to do. Hurt doesn't necessarily equal harm. My body is resilient. I believe in my healthcare team. What a relief. My MRI showed nothing serious. Sometimes I have to say some of my patients with chronic pain, it is so hard for them to get imaging or test results that are negative, or like it's almost easier for them to have a positive test or have something show on the MRI. But I think reframing and saying like, hey, what great news. There's nothing in your MRI that is pathological, that shows severe injury. This is good. When patients start to say, I can manage this flare-up by myself, and finally, I don't need to be pain-free to participate in things that are important to me. So, patients that are successful are also actively addressing mental health issues. So they are establishing and using helpful coping strategies. They're accepting recommendations from mental health services. They understand the signs of depression and anxiety. They find community in support groups. They might pursue things that they learned in their therapies like relaxation or mindfulness. That's, these are characteristics of patients that do well once they've been discharged from care. And then lastly, really important to address physical health. So empowering patients to stay active, to be involved in community programs like aquatics, yoga, tai chi, walking. And I think here it's really important to make sure that looking at the patient's own, looking at the patient's own interests is going to be really valuable here, and not just trying to recommend something because, well, other people find yoga to be helpful, so you should do yoga. I think we really need to cater to the needs and interests of our patients. We recommend good sleep hygiene. Sleep is where tissue is repaired. Nutrition, smoke cessation, alcohol consumption. And then this is a big one, is following safety recommendations. So a lot of patients in the older population have a very tough time accepting potentially that they need to use a cane or that they need to use a walker. I think really encouraging our patients to understand that these are the things that are going to help them do more in their communities. These are the things that are going to help keep them out of illness, help keep them from being injured. I think as providers, it's really important to try to reinforce these things. I mean, additionally, in looking at the literature for the older population specifically, 3 physical health conditions came up very frequently: obesity, fall risk, decreased mobility, and physical functioning. And we did find actually that in some of these studies, decreased mobility and physical functioning in an older population was actually a little bit higher incidence in female population. So, how do you refer your clients and their patients to the right care? We've already talked about understanding the difference between, new versus chronic pain. So if your patient has new or acute pain, it's appropriate to refer to single service providers such as physical therapy, primary care physician, or a gerontologist, orthopedist. Certainly a physiatrist. I think the thing, when my family, comes to me, Maya, I hurt my back or I hurt my knee, I very often do recommend a physiatrist because I do feel like they're very pro-active care, very pro-physical and occupational therapy. And they do, in my opinion, do a really nice job of looking at the patient holistically. They believe in, the value of psychology and psychological intervention, mental health intervention. So, if your patient has more of the persistent or complex pain, or the pain that's less associated with the tissues, then as we discussed, the ideal treatment intervention is going to be an interdisciplinary approach, right? So it's widely considered the gold standard. This will be the best recommendation that you can make for your clients if the resources are available. But in the absence of this option, it's helpful to understand the components that are important in providing effective care. So, kind of in summary, care that encourages active versus passive approaches, care that utilizes a biopsychosocial model. These will be seen by like a physiatrist, PT, OT, certainly psychology. These are providers that will be really beneficial. Of course, as a physical therapist, I want to really highlight the role of physical therapy. I think physical therapy does a really nice job of providing primary care. We do a good job of screening patients and identifying when they need to go back and see a physician or when they need other services like mental health services. But essentially, when you are referring or wanting to make a referral for physical therapy, again, understanding whether an injury is simple or new versus chronic and complex is going to be really helpful. So what I tell patients is when they have a simple or new injury, convenience is going to be really important. So looking at therapy providers in the neighborhood, in the community, things that are easy to get to. Some of the storefront type of therapy places will be able to get patients in quickly, which when it's a new injury, that's actually pretty valuable and important. They'll have flexible or late hours. But in general, they do a really nice job of getting in those acute injuries, seeing them quickly, seeing them frequently as needed. And they do definitely excel in the use of those like kind of acute interventions like ultrasound and massage, manual therapy. I think that when you are dealing with someone that has a chronic problem, or they just have other comorbidities, they're just a complicated, complex patient, I usually recommend a hospital-based or academic institution. I think that in these situations, there's opportunities for additional services. They tend to be more one-on-one model of care. They may spend more one-on-one time with the patient, like a 1 hour or 45-minute model. And I do think in a hospital-based outpatient clinic, they will tend to be a little bit more interdisciplinary, have access to physicians, have access to psychology sometimes, even nursing or just other providers, whether it's like pulling in occupational therapy or, something like that. I think it's really helpful. A good resource that I do utilize with patients is choosept.com. It's a site that's powered by the American Physical Therapy Association and allows you to search physical therapists by zip code. And here you can also see when clinicians are board certified. So again, with a complex injury, especially if you work with clients or patients that are in very rural areas, I think you may not always have the opportunity to choose an interdisciplinary program or a hospital-based program, but it is helpful to see what's in the area and are there any specialists with like board certifications in either geriatrics or orthopedics. I think that is really helpful. Kind of in summary, we know that finding a good provider, but certainly a good physical therapist, is someone that utilizes a holistic or biopsychosocial approach, certainly someone that can identify the importance of a psychologically informed approach. Pain science education, I hope that I emphasize the importance of that enough. Active versus passive treatment, and then promoting self-efficacy. And I am ready for questions.
Thank you so much, Maya. So one of the first questions comes about people that sort of quit seeing their physical therapist if they feel like they're sore the next day or they have more difficulty with mobility. I think particularly following an initial evaluation or anything. So strategies on how social workers and care managers could talk with their clients and kind of give them the right advice.
That's great. And that happens a lot. So a lot of the patients come in fearing PT and kind of not wanting PT because of that exact reason. So I think the best thing that you can do for them is empower them to communicate with their next provider, or even the provider that they just saw and fired them and broke up with them. Empower them to go back to them, let them know what happened, let them know that they continue to be worse, let them know, that these are the things that you're experiencing. Because what I always tell patients is we as clinicians, we don't know how to adjust if we don't get feedback from our patients. So it's just super important to come back and let them know what's going on. And I think just, can we maybe adjust what you did so that we're kind of gradually ramping up to what you'd like for me to do versus, going into, I think what the older population was tough is you have, two sides of the spectrum. On one side, you might have clinicians that, kind of don't know where the breaks are, and well, more is better, no pain, no gain, right? But then on the flip side, you might have clinicians that are like, oh, well, because you're 80, I think we can just do like 10 sets or 10 reps of this sit to stand, when in reality, we need to make sure that we're challenging our older population just as much as anyone else and in an appropriate way.
Can you speak to sort of the difference between the chronic pain program at ShirleyRyan versus like outpatient physical therapy? And then what's the level of sort of similarity between ShirleyRyan's chronic pain program and other hospital organizations?
Wow, that is I could do a whole nother lecture on that. I think, I wanted to make sure that I focused on non-interdisciplinary care in my talk. So at ShirleyRyan AbilityLab, our chronic pain program has multiple providers. So they'll see a physical therapist, occupational therapist, a psychologist. Sometimes they'll receive biofeedback if their insurance covers it. Some vocational therapist. And they'll have a medical provider that's kind of leading the team. They'll receive pain science education. They'll receive a lot of cognitive behavioral therapy intervention and education on the value of psychology in the treatment of chronic pain. they'll receive individual as well as group therapy. And so there's a lot of opportunity for really learning from others' experiences and, you know, just all the benefits that group therapy provides. Now, at ShirleyRyan AbilityLab, in the outpatient department, we do have some physical therapists that specialize in chronic pain, but I would say that's not always what's available. So we all kind of work together to educate ourselves and kind of be uniform in our training. But I would say, you know, our PTs here at ShirleyRyan do focus on the pain science education, focus on really, you know, all those components that I talked about. I think what's a little bit more prevalent is more traditional physical therapy, where there is more of a targeting of tissue versus understanding the neurological components of persistent pain. Did I answer the question? Was that okay? There were a lot of parts to that question.
I know, sorry. Bad moderator here, throwing complicated questions. Last thing is, what advice sort of would you have for non-physical therapists to provide to clients, thinking sort of the scenario of someone who's like, I'm having a lot of pain today, I'm just gonna lay in bed. So what sort of health promotion, exercise, physical activity guidance could care managers and social workers and other non-PTs provide?
Yeah, I mean, I think educating your clients and patients that there's really good research out there that shows that active, you know, therapy, active movement is really beneficial in the management of chronic pain, even if it involves just getting on a walking program and initiating some kind of, you know, understanding what baseline you're usually operating on and increasing that baseline by 10 to 15% a day of walking. If walking is too difficult, you know, would it be an aquatic, you know, aquatics class or maybe a chair yoga class? But really just letting them know that the research is very clear that any type of active movement is going to be beneficial. And I think encouraging them to see a clinician. I think that's another piece that's really important, because I think it's going to be hard. Every patient requires something different. So I do think initially having the right prescription for that patient is a great place to start, even if they're not involved in a 3 days a week for 12-week physical therapy bout. Even if it's just a consultation for 2 to 3 sessions to really get them started, I would encourage that.
Great, thank you so much. We're going to shift gears to our final speaker of this morning's presentation. So hold on one moment while I bring up those slides. All right, Dr. Merriman, the floor is yours.
All right, well, thank you for having me. And after listening to Dr. Margolis and Maya, they covered a lot of the stuff that I'm going to cover, the role of psychology in treating pain and in the perception of pain. So my first pain program was in South Bend, Indiana, back in 1988. I had a master's degree at that point, and it was a multidisciplinary pain program that was modeled after the one at RIC at the time. So we had our medical director, who was a retired or semi-retired neurosurgeon, who had been interested, and so he trained himself, or he got training in acupuncture when he was in his 60s. He's a wonderful man. The program was a group program, so patients came in at the same time and finished at the same time. It was a 4-week program, and Monday through Friday from 9 to 4. We had physical therapy, occupational therapy. I have to look at my notes. biofeedback training. We had a nurse who was weaning all of the patients off of any opioids they were taking at the time. This was 1988. And so it was the first kind of purge of opioids from pain patients. That's happened a few other times from then. And we also had a vocational trainer from the state that would come in once to meet with patients and kind of describe what the services were with the state. It was a great program. The patients as a group tended to cohere and help each other. And at the end of the program, at the end of those 4 weeks, most of those patients were doing better. There weren't a lot that were pain-free, but they were more functional. They felt better about themselves. There was just a lot of positive aspects to it. And maybe one of the things that helped was at the end of every day, we would put all the patients and I would go into this big room where we had 12 lazy boy recliners. And I dim the lights, put on the heart music, and lead them through a progressive muscle relaxation exercise or an imagery exercise. And it was interesting to me to see, like, at the end of the first week, they're still kind of moving around and just not throwing the thing. By week 3, when I turned down the lights, you could see the tension just go out of their body at the end of the day. It was a really good program. And it, at the end of, when they had their first PT evaluation, we would videotape them. And at the end of the program, we'd all sit down as a group, everybody, patients and staff, and watch those videos and compare them with how the patients were doing as they were leaving. We, as a staff, sat down after one group at some point, and we wanted to figure out, okay, what is it about this program that's helping patients? You know, besides the obvious. I mean, they're getting good treatment. But what we figured out, what we came to was, it was because the biggest factor involved in their recovery or their improvement was that we never questioned their pain. They came in, and if they said their pain was 100, their pain was 100, and you go with that. Nobody ever said 100, but they felt they had been judged a lot in the past, and I think that's one of the things that happens with our patients is that I'm sure it is that family members, co-workers, a lot of people just kind of it can't be that bad, and there's at the end of this a list of things never to say to a pain patient, and that's one of them. So that program really inspired my desire to continue to work with pain patients. I left there to get my PhD so I could be a real psychologist. And after that, I've worked in several. I've been at the pain center at Rush for 16 years, a record. And what I do with the patients there is I do a lot of evaluations of patients who are being considered for implantable devices. The doctors do a lot of that. But I see a lot of patients who are dealing with distress of many forms. It's a misunderstanding to say I help patients with their pain, because what I do is help patients with their response to their pain. So the anxiety, the depression, all of those things, those are what I work with for the patients. And if we can, let's see. Sorry, I'm on paper. Pause. Second. Yeah, sorry. My brain is going good right now. Could I have the second? Yeah. Slide. Sorry. So this is the definition of pain from the International Association for the Study of Pain. And I won't read through the whole thing, but it's important to read through the first part. And it is that pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. And number one, pain is always a personal experience that is influenced by varying degrees by biological, psychological, and social factors. So an important understanding about pain is that it is a perception. It is much more than just any tissue damage that's been done. And this perception of pain develops as we grow from the time we're children and learn that pain is scary and horrible from parents, or sometimes we learn that it's not a big deal, just rub it off and get going again. The meaning of the pain to the patient makes a significant difference in how the pain feels, not just how they feel. So if they're afraid of the pain, yes, they're going to have anxiety, but the pain is also going to be experienced as more intense. And that's what we have, that's what we focus on as psychologists, is trying to make sure that the thoughts that they have, excuse me, and the things that they do to try and help with their pain are in their best interest. So, number two, excuse me. So as is a perception, the factors that determine our experience of pain include the signals from the source, but everything else we say to ourselves and have learned in the past. Functional MRI was developed, I think, about 20 years ago, and it has provided a great deal of information about what goes on in the brain when we're in pain, or the brain in pain. And it's true that even just imagining the pain, when you don't have the pain, there's been studies galore, show that there's activity in the sensory cortex, and that's where pain signals go from the tissue that's damaged. But in this case, it's coming from memories or from some other input, and patients can feel increased pain when they are even just imagining what the pain would feel like. There is a lot of research being done to see what can be done to alter those thoughts and processes. And we're not going to go into the brain, but there have been efforts by interventional doctors for going in with like deep brain stimulation for pain management. And as far as I can tell, that has never really been effective. It's not done, but it was in days past. Social factors play a large role in patients' pain experience. One of the first pain programs in the country was at Washington University, or the University of Washington in Washington State. And the psychologist who ran much of the program was a guy named Wilbert Fordyce. And he was a behavioral scientist, behavioral psychologist. And he believed that we can't know what's going on in the brain except by how a patient is acting, by their actions and the things that they say. That's all we can know about what goes in what goes on in the brain. So his program involved patients and their families attending for I don't know how many weeks. They'd come up to Washington State, and the family would be trained, and all of the staff had already been trained in ignoring the patient's pain behaviors and reinforcing good behaviors. When they did something that might have hurt and they didn't complain about it, that was reinforced. They'd be, oh, look what you did, that's great. And Fordyce believed that if you saw no more pain behaviors, you could assume that the patient was not in pain. And it's an interesting concept, but it didn't take for very long. I think it was, the program stayed around for many years, but that's not broadly what we consider as a treatment for patients' pain at this point. Although it is important that family members do not reinforce bad behaviors or pain behaviors. There's a lot of evidence that if somebody is moaning or just kind of winces, if a family member is, what's going on, then that does sort of reinforce it. So that's part of it. So if we can, next slide, please. I should actually. So again, we know that the experience of pain doesn't correspond to the amount of tissue damage. It is affected by everything you've experienced and believe, as well as by the pain, meaning of the pain itself. And that's determined by the patient. There is a great example of that that was recorded by a medic after a terrible conflict at Anzio during World War II. And he was working in the base camp medical facility. And what he noticed, his name was Booker. What he noticed was that guys who had been injured, even people, even soldiers who'd had amputations because of the injuries, were turning away morphine. They said they didn't need it because this is my ticket home. I can get out of here with this. And that kind of killed the pain for them. It's a really outstanding example of that. That doesn't happen that often, that we have that kind of problem, but it does. It was a great indication because there wasn't just one or two, and yet the patients who were citizens in Anzio who wouldn't be going anywhere because there was no home left, they were in severe pain and required a lot of medication to help. I think that both of my prior instructors brought up psychological treatment as a big part of pain management. And I think, you know, as a psychological pain doctor or a pain psychologist, I would have to agree. Next slide, sorry. If we talk about what happens, comorbidities, how does pain, and especially chronic pain, affect an individual's life, and not just because of the pain, but it does affect interventions or relationships with their family members. Friends tend to shy away from people who are in pain. Oftentimes our pain patients are not able to work. We have a lot of patients who are on disability or have workers' compensation claims, and that's a whole other source of stress. Anxiety is a very common response to pain, and the somatic symptoms of anxiety, increased heart rate, kind of muscle tension throughout your body, can also exacerbate certain types of pain. So that's not a great thing. Depression is also at times a response to the pain. And when the doctor talked about, you know, patients whose behaviors were going slower and slower and slower with treatment that didn't work. And it's partly because of the pain winding them down, but anxiety and especially depression can make a person lose any kind of motivation. And it's a feeling of hopelessness and helplessness. Not only can I do nothing about this, this is never going to get better. And those are statements that are really, really damaging. When patients feel that way, it needs to be addressed, and not with, it's going to be okay, but the doctor who is treating them and the other people who are working to help this patient to find other ways of thinking about their pain. Social isolation occurs. People move away from the things that they value when they're in pain. One of my patients, when I asked her what people should know about pain, and she says, it makes you tired, it exhausts you. And if you've ever even had short-term pain, you know that that's the case. And medication can also be a problem in that families, I don't want you taking that medication. I don't think you need that medication. There can be arguments about that move people away. It's a really tough road to hoe. And if there is trauma that caused the pain, the more comorbidities can be even more difficult. It's not uncommon when I'm asking patients how they're doing and come to the question of any suicidal thoughts. Patients will frequently say, well, I don't want to kill myself, but you know, last night when I went to bed, I said, just don't let me wake up. And that's unfortunate. So next slide. So treatments, organized treatments for psychological treatments for pain cover a few things. So cognitive therapy and cognitive behavioral therapy, you've probably heard about them. Both of them, and they're very much interconnected. You can kind of swap them out, although with cognitive therapy, there's not as much attention to doing things like teaching muscle tension or muscle relaxation things, but it is more involved with, and this is the most important part of psychological treatment, is just paying attention to what you're saying to yourself about your pain. And with cognitive therapy programs, you know, where you're doing it, there are worksheets. And so you fill out these worksheets when there's a stressful event or something where your pain is increased, or you're thinking bad thoughts about the pain, you feel helpless. What are the thoughts that are going through your head? And then at a later spot, you sit down and you say, okay, how valid are those thoughts? You kind of challenge them. How much do you really believe this thought? And is there anything you can come up with that contradicts that thought, the validity of that thought? It sounds kind of heavy, but it's actually pretty easy to do. I mean, to do the homework, but then making some changes and coming up with a more adaptive thought to replace the one that isn't helping. So for instance, a really damaging thought is, this pain is killing me. And I hear that a lot, and I imagine everybody does. When of course pain is not killing them, it's kind of destroying some of their life, or they feel that way. But it also makes them feel more helpless and more doomed. So that would be a great one to say, okay, what else could you say instead of that would express the frustration that you're feeling right now, or the distress? And it would be something like, I really hate this pain. It sucks. So what can I do to help myself right now? Things like that can make a big difference. And once they've done a couple of weeks of work with a therapist for that, they find that they can do it on their own. And kind of self-correct as they go along. We did a study, but it wasn't involving chronic pain. It was involving patients who were going to have joint replacements. And I would meet with them for 4 sessions of cognitive therapy, focusing on pain and stress management before they had the procedure. And then I had with them 1 session afterwards. And this was by either in person or on Skype. And the patients found that participated tended to do much better post-operatively, followed up with their doctor's recommendations, and took their pain medication as prescribed, and didn't freak out at the beginning because they had some things that they could fall back on to calm themselves. Cognitive and behavioral therapy includes some of the behavioral factors that were involved in Dr. The guy in, I just lost his name, the guy in Washington, but also introducing relaxation training, knowing how to move and kind of paying attention to what's going on in your body as well. Acceptance and commitment therapy is a relatively new area, and it took cognitive therapy and kind of added some factors to it. So it definitely involves developing goals and a lot of acceptance about how things are without feeling like that's a loss. They also include some mindfulness methods in those in that type of treatment, and people's excuse me, people's values are a big part of determining what to do and how to do the therapy. So they want people to get closer to their values. And when you live to avoid pain, or when all your decisions are made in an effort to avoid pain, that tends to move you away from the things that you value. Biofeedback, it is really helpful for patients who need to decrease their somatic arousal. So when we talk about these negative statements that we make to ourselves, sometimes they can, when we talk, activate the sympathetic nervous system, just get you worked up and everything is kind of in high gear, like it's a fight or flight response. And so learning how to decrease and turn that down, biofeedback training can help, because you've got some objective feedback from this machine that tells you that, yes, my temperature is heating up, it's warming up, and that's good in your fingers if you're stressed. Or, yes, my heart rate is going on. I can take deeper breaths. It's really a helpful tool, but I'm not sure that it's used very much these days because insurance companies generally won't pay for biofeedback training sessions. Excuse me. Hypnosis is also a tool that can be used with some effect for patients, not to take the pain away, but again, to help them to talk differently to themselves about the pain. So a great example is with a patient of mine who was always thinking about her pain, just always, always, always. And in hypnosis, what I would have done had I done it was to say to her, now imagine how wonderful it's going to feel when you don't think about your pain as much. And that alone would be a helpful statement to make. And if she could take that as an expectation, it would help her to not focus as much. Positive psychology is also really new. And it is not saying to yourself, everything is going to be okay, but it's taken from the belief or the observation that we as human beings tend to focus on everything that's effortful and not see some of the stuff that's beautiful. And so in practicing gratitude, where you have a little notebook and every day you write down 3 or 5 or 2 things that you're grateful for that day, patients who, or subjects, I should say, in studies who do that for a period of 6 weeks tend to show changes in energy levels, in just general mood. Just that's a better way of looking at the world than just looking at the bad stuff. So I kind of integrate that in treatment with patients by the practicing gratitude part, so that they can balance out. Yeah, the pain may be awful, but you've got this wonderful home and this house and these people who love you. So kind of balancing the negative and the positive, so patients aren't thinking that their whole life is just junk. Mindfulness practice is also a very useful tool. So focused breathing exercises, I recommend to just about every patient that I see, and I do them myself, although I'm not doing it very well right now. And that's the main one that I see, because it's very accessible. Other types of meditation are also useful for patients who are accepting of doing some meditations that take longer. But it is a matter of overall being in this moment and not worrying, not being in the future or the past or something terrible all the time. When you start thinking about how you got hurt, then instead catch yourself and bring yourself to right here and now. Slow your breathing and just kind of let go of those thoughts for the time being. And with enough repetition, it helps to decrease or eliminate those negative thoughts. Next slide, please. So here are some things that I've got from my patients, have given me information. These are things you never say to people in pain. And one of them, it can't be that bad. Or you look so nice, you must be feeling better. They really hate that one. When a person is saying, yeah, my doctor can't figure out what to do. Well, why don't you find a new doctor? You should see my doctor. My doctor, yeah. Offering any kind of recommendations, unless you have something really positive to move along with. Don't give them blue goo motivations. Another one, you think you have pain, I'll tell you about pain. There are some support groups online for certain types of pain, and I've learned that there's patients who have told me that some of them feel like they're competitions for who has the worst pain, and not helpful in the least bit. So I think that's about all that I have to offer, and I'm sorry I'm kind of like, but I'm hoping that you got something from this. I will say that I love what I do. It's really, it isn't draining. People ask me, you must get, it's more like, I don't know. It's just that patients who will honor me by talking about how they feel and listen to what I have to say. I think that that's just amazing. And I guess the other thing, when I say never say something to these things, the other side is, please be respectful, as the IASA recommends. And that's about it.
Great. So we've got time for a few questions right now. So one of the questions is, what should you say to someone who is in pain?
You can say, well, it depends on what they've said, but, being, what's the right word? Just say, yeah, I'm sorry you're hurting so badly. That's fine, if you really mean it. I mean, I guess I'm saying avoid giving advice and avoid being too, oh my God, it's going to be terrible, too much. But yeah, certainly asking them if there's anything that you can do to help, if they're having physical problems where they can't do things. What might make you feel better right now? What could I do to kind of get your mind off of that? Things like that are good.
Can you say a little bit more about how mindful practice helps sort of being in the moment for those who are experiencing pain at that particular moment?
Good point. It does include being, well, if you're in the moment, okay, so if I'm in pain and all I can do is think about the pain, if I step outside and say, okay, birds are singing, the sky is blue, I am picking up information from around me instead of focusing on what's in my head. So mindfulness is being mindful of your environment and sometimes how your body feels as well, going through, and is there tension that I can let go of? Is there something that I'm needing right now? But mostly it's the distraction, and that sounds so simplistic, but distraction, as it's shown in ANSIA, is a really important tool for patients in pain. Finding something that they can focus on away from their pain. And sometimes the pain is too severe and they can't do that, but sometimes they can. And so, yeah, I guess that's the response.
Can you share some practical interventions that social workers can try with clients who have chronic pain? And Maya, feel free to jump in too if you have any comments, but really looking for sort of those practical interventions that a social worker can try.
Practical interventions. I think the question is, well, you'd have to start with how are you feeling today? And that's a hard one. And then going from there, if they say my pain is like, well, what do you know? Do you have any idea what, if anything, happened that made it worse? And kind of seeing if they can identify some of the factors that might have increased their pain. You know, well, it turns out that somebody they love was in an auto accident the night before, and ever since then they've been in a lot of pain. That could be certainly something that goes along with that. So kind of asking them questions that help them to think about what things outside of their physical symptoms could have been affecting their physical symptoms, if that makes sense. So, you know, did you sleep well last night? Did you have something? So, and in terms of intervention then, I suppose, I don't know how to answer that part exactly, but being present with them as well and non-judgmental when they talk about the pain, those are sort of the rules. And if you feel empathy, and this is something that I forgot to mention, in some of these fMRI studies that they're doing, they have discovered, I guess is a word for it, that there is a physiological basis for empathy. So when we see people in pain, our sensory cortex lights up as well, and we feel that pain. And I started thinking about that when I was getting ready for this, and I thought, well, that's wonderful. And then I thought, maybe that's why people in pain are so much pushed to the side, is because people are really uncomfortable when they see people in pain. And so they get a lot of dismissive stuff because of that. So pay attention to how you're feeling as well when you're talking with this patient. Yeah, and just listen to them, because they don't get listened to a lot.
Great answer there. Very helpful thoughts to consider our own sort of emotions and responses. When we're thinking about sort of the assessment of people with pain, is it helpful to use a numeric pain rating scale, sort of the 1 to 10 scale, or does that place more emphasis on the pain, and what tips might you have for assessing pain?
I think it's funny you ask, because a patient told me just the other day, last week, why do they ask about what my pain is right now? Because that gives them no information about what my pain was yesterday or the day before, or what it is in general. And she just went whew, on a real rant because she thinks it's stupid. And it's widely used. Our doctors use it every time somebody comes in, what's your pain today? And I don't really see it as very valuable, because a 7 today can't even be compared to a 7 next week for the same person. You know, it's just, but we don't really have much else. We don't have any way of measuring pain. And that's one of the really difficult, you know, there just isn't a way. It'll be interesting to see when fMRI gets along to where we can do a shot like that to determine how much pain they should be feeling and how much they're reporting. I don't know.
I think if I can jump in, I think it's definitely a fine line, because you want your patients to be a little less pain focused. So then you're asking, well, what's your pain level now? Well, what was your pain level after the group? What's your pain,
Yeah.
So there's a balancing act to play. But I think when we're talking about self-efficacy and teaching patients how to pace, it is important to make them aware of, like, what is your pain rating before you start the activity, and understand, how high it gets, and giving them parameters of like how much, like, it's okay if you jump up 1 or 2 points. But then again, that doesn't work for everybody. I think just being flexible and understanding that everyone has their limits with the pain, the pain rating scale is just really important. I think being able to be flexible and accommodate the patient is really the best.
So two thoughts too to add. One is that the VA has a fabulous pain, 0 to 10 pain picture thing. So it has colors, it has faces, it has numbers, it has a description, which I really like. And that's a little more useful than just saying 0 to 10. The other thought was what? Now I lost it. Thinking in terms of functional abilities. So how far we were able to walk, like when patients are going to have a stim trial, my spinal cord stimulation trial, I tell them, okay, and the week before that trial, I want you to think about how the pain interferes with function and get some baseline data as to how long can I be on my feet before I have to sit down? How long do I have to sit before I recover? And do the same things during the trial to see if it's really helping instead of just kind of relying on how it feels. Yeah, so functional improvements is a big way of looking at pain.
That's great. I just want to note that thank you to someone who shared the VA pain rating scale in the chat. I've not opened the link yet, but it appears like it is publicly available. So that's a great resource. I'm also wondering if you could speak to the role of being in a group and group activities, group interventions for people with chronic pain.
There are good ones and bad ones. Like I said, the one online, that's all a competition for who had the worst day. Do I have time for a brief story? This is really fun. So when I was working back in Indiana, there was a patient that I saw once who came in, or a couple of times, and she had been diagnosed with fibromyalgia. She was an older woman. She was in her 60s, not that old. She had just got the diagnosis and she was pretty depressed because her sister had also died and So I see her a few times and she says, well, my doctor told me that they have a support group here at the hospital for patients with fibromyalgia. So I think I'm going to go there for a few weeks and see what happens. So I don't see her for a few weeks. She comes back and I go out to the waiting room to get her and she's like chatting away with somebody and she looks great and she's really happy. And I kind of said, what's going on? And she said, well, I went to that support group and there was a lot of women and they were mostly women, and there were a lot of women in wheelchairs. And so everybody started talking. The men didn't say anything. I think they were just spouses, she said. And the women started talking about not being able to work and And I said, well, I'm still working. And they looked at me and they said, you won't be for long. and then they started talking about how they couldn't do their housework and they couldn't do these things. And then I said, well, I'm still doing that. And you won't be for long, she said. So I didn't say another word afterwards. I got out of there as fast as I could and I never went back. And I decided I'm giving up sugar. I'm going to walk every day for 2 miles, no matter how much it hurts. I'm going to do this. I'm going to do this, and I'm not going to be depressed. My sister wouldn't want me to be depressed. And it was a great support group, but for the wrong reasons. So it's important to find support groups that have somebody moderating who knows something about it. Doesn't have to be a professional necessarily, but somebody who is good at keeping things moving upward, helping people up, not getting them down. Yeah, and I think that in groups like that, it can be great.
I would say at the Pain Management Center, patients often talk about how helpful the groups are, but they all are moderated for that same reason. There's a lot of redirection that occurs, but the patients do say that the group is very helpful.
Well, unfortunately, we're right at 10:30, so we're at the end of our time for today. I apologize we couldn't get to everyone's questions, but thank you very much to our speakers. I hope everyone learned so much. We'll send out the survey, and I'll turn it over to Gail for any closing remarks.
Thank you so much, Margaret, and thank you all very much for the great content today. Yes, as Margaret mentioned, you will be getting an email at the conclusion of this webinar. Please complete the evaluation and we will send you their certificate. So thank you again for joining us and we appreciate it. And we'll see you at the next CE.
Okay, bye.
Bye.
Thank you.
Bye.